So are there special end-of-life considerations for someone experiencing homelessness?
Yeah. Yeah, and this is my own, this is my whole program of research in an area that I've been working in for quite a long time. So I think there's a few things to think about. The first is that, like, we think about, first of all, we think about palliative care as people being in the last weeks of life. And palliative care and a palliative approach to care is really taking an upstream view of looking at people who have serious illness, and who have advancing progressive chronic illnesses like cancer and COPD and kidney failure and liver failure. And a lot of people, like in palliative care, we've put out the question, is homelessness a terminal diagnosis? Because the average life expectancy of a homeless person is, not the average life expectancy of the average Canadian, right? Like, I don't know what the last stats were, 34 to 49 years old as the average age of death. So we have a large number of people who are dying, for whom I think we don't notice at all, and we don't actually identify them as people who are dying. And the folks themselves and the service providers that care for them, by and large, don't think about palliative care, because people are just in survival, right? Like, people themselves are trying to survive, to get shelter, to get food, if they have substance use issues, to make money, so whether they're dying or not, that's not the first thing that's on people's minds. So I always say to people, in my mind, attending to the social determinants of health for somebody who is, progressing toward death is a palliative intervention. It's actually the first intervention. Like, in palliative care, we often talk about pain and symptom management as, like, that's a big thing, that we have expertise in palliative care. And, we always, in kind of mainstream palliative care, we always say, well, we can't actually do much unless we get people's pain and symptoms under control. In this context, we can't do much, we need to get the social determinants of health needs attended to before we can do anything else. So one thing is, so we have a population of people where they're just trying to survive, and palliative care isn't on their radar necessarily. Because of the lack of safe supply for people who are drug users and are also homeless, because of the toxic drug supply and the criminalization issues, we have an issue where dying seems to be normalized in the community. So that, so that doesn't help us in terms of identifying people who could benefit from a palliative approach to care. And I think, like, a lot of these folks are folks that go in, they have an exacerbation of an illness, they go into emergency, they maybe get some treatment, they come out, they go back in, they come back out, but nobody ever kind of says, oh, like, this person's liver failure is really advancing, like, maybe we ought to think about talking with them about what's important to them, like, what do they want done. And in our research, whereas, if I had end-stage liver failure, I would probably say, I don't want any heroics done. A lot of these folks actually do, because they've survived so much already. So, if you have a substance use issue and you've survived multiple overdoses, you think, well, I can survive pretty much anything. So we can't make assumptions about what people want, and the most important thing is to talk to people. One of the things we did in Victoria that I think has been such a game changer for a lot of folks in the homeless community is we developed with people with lived experience and their outreach workers, we developed an advanced care planning tool. And we have our teams and we have outreach workers and housing workers doing advanced care planning with people. And that's been a total game changer, because when somebody goes into hospital, what happens is if they don't have strong connections with their biological family and they can't speak for themselves, they have no way of communicating what is needed. And we've had people that have been in our studies where they went into hospital, they've died, and later on their friends in the community have said, oh, you know, like he really wanted me to he wanted to give me that Detroit Red Wings, sweatshirt that I had, and it got tossed in the garbage. That is heartbreaking for people in community. So we're really trying to, put things in place to really ensure that people's decisions are documented, that we're really careful about trying to make things unfold in a good way for people. I think the other main issue around end of life care, well, there's lots, but a lot of folks are estranged from their biological or biolegal families. So family looks different in this context. So it could be friends that and family that some people call street family or chosen family, and they're in a kind of a situation where they don't have any legal rights. But if you think back, say years ago, to the AIDS epidemic, when you had partners who were the closest person to the person dying, and they weren't allowed. It's the same thing for homeless people. They go into hospital, they don't have connections to biolegal family, but they have people in the community that they're really close to, and we don't recognize them as having legitimate say in what happens. So that is a consideration for sure. And I think the other big thing is, as a healthcare system, like in palliative care, we often want to support people to die at home. People either don't have a home, or if they have a tent or something like that, or they might live in an apartment, but healthcare workers don't want to go into those spaces to provide care. And I would say there's a lot of like risk management, and kind of like we can't go there because it's dangerous, and maybe in some situations it is, but for the most part, I think it's our own fear getting in the way of bringing services to people when they're at the end of life, and otherwise. So, I think when people are at the end of life, they still face all the same stigmas, all the same discrimination that they do in the healthcare system and by society as a whole. Our attempts at kind of having these, I would say, these mobile palliative care services that do a lot of work on community development as well. So that we're not like some service jumping in and saying, okay, we're going to take over and we're going to do this, but it's more a model of how can we build capacity and strength within community, working alongside people in community to really flatten those power differentials. And that's, I think that's what some of those programs are trying to do across Canada.
It's very interesting. Very interesting.